And I think it's time to introduce the first speaker. So we have, first of all, Francesca Moro, who's going to talk to us about the fundamentals of carrying out a vaginal ultrasound scan. Obviously, if you're going to use ultrasound for diagnostics, you have to start with the basics and actually know your anatomy. And Francesca is going to talk about normal anatomy and the basics of carrying out a scan. I think having seen this lecture before, it's a great lecture. So Francesca, looking forward to hearing from you. Thank you.
This is my presentation, the fundamentals of carrying out a transvaginal ultrasound scan, including illustrating normal gynecological anatomy. In this presentation, we'll discuss how to perform a transvaginal ultrasound examination, how to optimize the image, how to assess uterus and ovary, and also how to assess the parameter, anterior, lateral, and posterior parameter. First of all, how to perform a transvaginal examination. So we insert the probe in the anterior vaginal fornix, and then at the ultrasound scan, we can visualize the uterus and bladder. Now we can check the caliper position adjacent to the bladder. It can be on the right, on the left, at the top, or bottom. It depends the setting of our screen. We usually scan with the caliper in this position. Now, how to optimize the image? It's very important to use depth and zoom to obtain the image. This is an example how to obtain the correct image of the uterus using depth and zoom. The image of interest, as the uterus in this case, must occupy more than 75% of the screen. This is another example how to use the real zoom. We can assess the uterus. This is the normal uterus with the endometrium, and we can use the zoom, the real zoom, this is the box of the zoom, to better assess the endometrium. We can measure it, and we can also assess the vascularization. So the real zoom helps to enlarge an image section on the monitor without the grain effect. So depth and zoom. Focus. Adjusting the focal zone, single or multiple, to the area or just behind the area of interest will increase resolution and therefore image quality. For example, this is the uterus. This is the incorrect position of the focus, and this is the correct position. So focal zone to the area or just behind the area of interest. Please check also the frequency. We can have 3 frequency settings: resolution, high frequencies to investigate superficial structures, general, intermediate frequencies, or penetration to study deeper structures. To assess the uterus and ovary, we also use general frequency. So, to obtain a good image to the uterus, for example, we can use general frequency and the focus in this position. Also, gain. The gain increase, when we increase the gain, we increase the echogenicity of the organ. It's important to check the gain to obtain the correct image. We can see the first one the gain was incorrect, we can in the second one the gain was obtained correctly. What about color Doppler examination? Two important points. First one, check the PRF. The PRF should be in between 0.3, 0.6. We can see here an color Doppler image of the ovary with the corpus luteum, and the PRF was at 1.5. The same image, but with the PRF at 0.6, we can observe the ring of fire of the corpus luteum. So this is the correct image. Then, second important point, when we want to perform a color Doppler examination, is the gain. So I suggest to increase the color gain until the appearance of noise, as in this case, we can see here the noise. Then we have to reduce the color gain until the disappearance of noise. Then we have the maximum color sensitivity without noise. So this is the correct image. Now we can assess the uterus and ovaries. So this video shows an uterus and how to assess the uterus. We can move the probe from side to side to assess all the organs. Then we can rotate the probe 90 degrees to assess the transvaginal, the transversal section of the uterus. We can measure the uterus in 3 axes. Long axis from the fundus to the cervix, and anterior-posterior diameter from the anterior to the posterior wall. And then in transversal section, we can take the third measure. Then, using the real zoom, we can observe and we can measure the endometrium. So we can move the probe on the right and then on the left side, following the broad ligament, to assess the right and left ovary. So we can measure the ovary with the 3 diameters, and then we can assess also the vascularization of the ovaries using the color Doppler. In particular, I want to show you that with the transvaginal examination, we can see the external iliac vessel. Then we can, following the internal iliac vessels, and then from the internal iliac vessels, we can assess the uterine artery. Transvaginal ultrasound examination is a dynamic examination, and we can assess the mobility of the ovary. This is the normal ovary. The ovary is completely free from the uterus, bowel, and the pelvic wall. And this is the laparoscopic view showing that the ovary was normal. Normal morphology, and also it was free, no adhesions. This is another video showing the ovary fixed to this hyperechoic tissue, corresponding to the uterosacral ligament. Now, how to assess ureter and parametria. So, to investigate the ureter, a longitudinal section through the cervix should be obtained to visualize the bladder and the cervix. Then we can move more laterally to visualize the terminal part of the ureter with the vessels, the uterine vessels. So the ureter is a tubular structure, anechoic tubular structure with no blood flow. So this is the ureter and they are the vessels. Before showing some video clips of the parametria, I want to emphasize that it's very important to know the anatomy of the structure surrounding the cervix. And in particular, we can divide the structure at the level of the cervix and those at the level of the vagina. In particular, at transvaginal ultrasound examination, we can assess the septa, the vesicovaginal septum between the bladder and vagina, and posteriorly the rectovaginal septum. So in the middle, we can assess the septum, vesicovaginal and rectovaginal septum. Laterally, also at ultrasound examination, we can assess the ligaments. So the vesicovaginal ligaments at the level of the vagina and the vesico-uterine ligaments at the level of the cervix. Posteriorly, we can assess the sacro-uterine ligaments at the level of the cervix, between the cervix and the rectum, and also the rectovaginal ligaments that are in continuum with the sacro-uterine ligaments at the level of the vagina. So now, first of all, I want to show how to assess the vesicovaginal septum. In this video, we can see the uterus, bladder, and this is the vaginal wall. So we can't see the septum, but we can assess the septum moving the uterus and the vagina against the bladder. And we can see that the uterus is free in this case. This is a video of a patient with an endometriotic nodule infiltrating the bladder. So we can see that in this case, the septum is fixed. So uterus, vaginal wall, bladder with a nodule. And this, when we push the uterus against the bladder, the septum was fixed. So this is the laparoscopic view showing the endometriotic nodule infiltrating the bladder. This is the same video, but I want to show now how to assess the anterior ligaments, anterior parameter, vesicovaginal and vesico-uterine ligaments. It's quite easy. It's important to obtain this section, including bladder and the terminal part of the ureter. This is my probe, my transvaginal probe. This is the vagina. This is the bladder. And this is the terminal part of the ureter. So this hyperechoic tissue corresponds to the vesicovaginal ligament caudally and the vesico-uterine ligament cranially. Then I want to show you how to assess the lateral and posterior parameter. To assess the lateral parameter, we can obtain a longitudinal section to visualize the bladder, the terminal part of the ureter, until the crossing point with the uterine vessels. At this level, I suggest to rotate the probe 90 degrees to obtain this image. So, ureter, vessels in the middle. In this section, in this transversal section, at the crossing point of the uterine vessels, we can visualize the cervix, the vagina, uterine vessels, ureter, and the pelvic wall. So the region between cervix and the pelvic wall corresponds to the lateral parametrium. Finally, to assess the posterior parametrium, I suggest to obtain this section in which we can visualize the cervix, vaginal fornix, posterior vaginal fornix, torus, and retrocervix. We are in a longitudinal section. Then we can move the probe laterally on the right side to assess the right uterosacral ligaments, so the hyperechoic tissue behind the cervix. We can move on the other side to assess the same structure, the hyperechoic tissue behind the cervix, on the left side. We can also assess uterosacral ligaments in a transversal section. So we can rotate the probe 90 degrees. We can visualize in this transversal section the cervix and the vessels. This hyperechoic tissue on the right, on the left, corresponds to the sacrouterine ligaments. Then we can move the probe more caudally, and we can obtain this section, cervix, vaginal fornix, and this hyperechoic tissue, right and left, corresponds to the rectovaginal ligaments that are in continuum with the uterosacral ligaments at the level of the cervix. So, according to the Matthew Leonardi, they suggest to move the probe in the posterior vaginal fornix in order to assess all the ligaments, the uterosacral ligaments on the right and then on the left. So we can assess first the uterosacral ligaments, moving the probe in the anterior vaginal fornix. And then to assess all the uterosacral ligaments, we can move the probe, we can insert the probe in the posterior vaginal fornix. So, to conclude the examination, we can assess the posterior septum, the rectovaginal septum. So, this is in this longitudinal section, we can see cervix, vaginal wall. This is the rectum, and by pushing the vagina against the rectum, we can assess the rectovaginal septum, that in this case is free. So, we have summarized the anatomy of parametria in a short video. In conclusion, so we can optimize the image using depth, real zoom, focus, frequency, and gain. Color Doppler examination. For color Doppler examination, it's important to get a PRF between 0.3 to 0.6. We can assess with transvaginal ultrasound examination the uterus, ovaries, and their mobility, but we can also assess the parametria, ventral parametrium, including vesicouterine ligaments, vesicovaginal ligaments, and vesicovaginal septum, lateral parametrium or paracervix, that corresponds to the tissue between the cervix and the pelvic wall with the ureter and the uterine vessels in the middle. We can finally assess the dorsal parametrium, including sacrouterine ligaments, rectovaginal ligaments, and the rectovaginal septum. And finally, thank you very much for your kind attention.
Francesca, thank you so much for a wonderful talk. It's such an important lecture to have on the program. We have a question from the audience, which I think actually is rather important, actually. It's the issue of measuring the endometrium. For example, if you have adenomyosis and the outlines is a little bit hazy, how do you manage that? Do you just say it's unmeasurable, or do you have any tricks or anything you might do in that circumstance?
Thank you. So it's true, sometimes, in particular in in the presence of adenomyosis, we cannot see the endometrium. We cannot assess the endometrium. And if the endometrium is not accessible, I advise to write in the report, the endometrium is not accessible.
I think one of the problems people have, I think, and in practice, is that I certainly know in London, if you start doing that, people say you're rubbish at scanning and go off down the road and see someone else. So what do you think, for example, in a postmenopausal woman, roughly speaking, what's the sort of out 10% of women unmeasurable, 5%, one, what's your kind of feeling?
I think 10% is
Yeah, I
not
tend to
measurable.
agree. How many times do you, for example, in routine practice, if you can't see the endometrium, do you ever put saline in and do a sonohysterography and put saline into the cavity? Or do you think that's only if you think there's focal pathology? How do you feel about that?
Yeah, I think that there is no if the patient is asymptomatic in postmenopausal and I can't see in the endometrium, probably I advise to do nothing because there is no reason. But if the patient is asymptomatic, probably I can advise to use the sonography or
yeah, so I think that's something we'll no doubt hear further from Thierry in the talks about the endometrium, using saline and so forth. Just finally, I mean, it's you ran through what I would call more straightforward stuff, and then the anatomy around of parametrium and so on. I mean, you demonstrated it so nicely, and in fact, it's kind of, how long did that take you to master, or is that something you got to grips with quite quickly? Because I think for some people, they find that quite difficult, the idea that you can see all these structures. But I mean, it's interesting. I mean, years ago, I never looked at ureters. I mean, when I started scanning, it wasn't something I did. But then it's actually quite easy, isn't it? You just literally move the probe.
Yeah, exactly.
So do you think, in fact, as a discipline, when you started learning, I guess from somebody, it's important just to look at all these structures for every scan you do, because that's the only way? I mean, how did you create your experience, if you like?
Yeah, I agree. First of all, it's important to know the anatomy, the pelvic anatomy.
Yeah.
And I spent some time with the Professor Curley and the other surgeons to better understand. But it's quite easy, really, to assess the septum because the transvaginal is a dynamic examination, but also the ligaments. So I agree. It's important, first of all, to try to check the parametria, to assess the parametria in normal patients, and then we can assess them, for example, in patients with endometriosis or cervical cancer.
Yes, because I think if you know what normal looks like, sometimes it's not normal. You might not know exactly what's happening, but you recognize it as being abnormal.
Exactly.
It's a bit like when you start doing obstetric scanning and you know the normal planes, and then it's like, oh, I don't know what that is, but I know that isn't normal. I think is a helpful thing to do. Someone else has asked about using saline in postmenopausal women, but I think we've touched on that. And I think
exactly.
For the person who's asked that question, I think we'll be talking quite a lot about that later on, because we've got some talks on endometrium later on. So I think we'll be covering that. So I think, Francesca, for the moment, thank you so much for that talk. I know we're going to have you back later on when you have cases for oncology.
Yeah.
So we'll be seeing more of you later. Where are you, by the way, at the moment?
I'm in the hospital.
In Rome?
In Rome.
Well, I'm sitting in a room in Soho House in Rome, down the road from you. You probably didn't know.
Oh, really?
Yeah. so very,
so fun.
very unusual. So strange international way of doing this. But there you go. Well, thanks very much. We'll see you later, and I'm going to
Thank you very much.
Pleasure. Hand over to Theo.
Okay.
Thank you, Tom. Thank you very much. And thank you, Francesca. Great talk.